Our renal system. So when we talk about perfusion to the kidneys, perfusion to the kidneys may be decreased. We hope not. We hope that the kidneys still have appropriate perfusion. But what are we going to be monitoring? What are things that we're going to look at? Urine output. But not only urine output, what about the urine? Specific gravity and color are going to be two of your big ones. What else are we going to look at? Urine and creatinine. We need to know the function of those kidneys. When we have burns and we have injury to the tissues, we have myoglobin release. Myoglobin is a very large molecule. It doesn't filter well through the kidneys. It causes a blockage of the renal tubulars. So it can put the patient in acute tubular necrosis. Also what we see when we talk about rhabdo is acute tubular necrosis. We have myoglobin release from the burn, and that myoglobin gets stuck in the renal tubulars because remember, those kidneys are not being flushed well. And so that urine with acute tubular necrosis will look like coffee. It'll look like tea. It'll be extremely dark and very concentrated. So when we start looking at the renal function of the patient, we can't always go by urine output. Now we're going to monitor it with burn patients, just like with any other ICU patient or sepsis patient. We don't necessarily go by 30 to 50 mils an hour. That is not appropriate for an ICU patient. We need to look at it by body weight. It is 1 mil per kilogram per hour of body weight. 0.5 to 1 per kilogram per hour. Because what I need to put out versus what Dr. Godwin needs to put out are two totally different volumes. So we use body weight when we look at urine output. When we are talking about burn patients from electrical burns, those patients will have an extremely high myoglobin release. Why? Because we have had damage to the entire body internally. So they have lots of myoglobin release. They are at a much higher risk of acute tubular necrosis. And so their urine outputs will have to be higher than that of just a thermal burn patient. But we're going to look at the color and the specific gravity of the urine as well. Acute tubular necrosis, uncorrected, can lead to acute renal failure. Acute renal failure, uncorrected, can turn to chronic renal failure. But at the phase of acute tubular necrosis and acute renal failure, typically fluids will fix it. Volume will fix it. So we are going to talk about that volume, increasing that volume to these patients. When we look at the central nervous system, these patients can have altered mental status. Hollis, tell me one reason a patient can have an altered mental status from a burn.
Poor perfusion.
Okay, hypoxia, poor perfusion. What else? Somebody give me another reason. Sodium's dropped. Patient's confused. Have y'all ever taken care of the patient that's hyponatremic?
Mm-hmm.
Yeah. Can we correct the sodium overnight, by the way?
Mm-hmm.
Nope.
That's a slow.
It is slow. As a matter of fact, I had an outlying facility yesterday wanting to transfer a patient to us for hyponatremia. You want to take a wild guess what their sodium was?
120?
112. So what do you think that patient looked like with the sodium of 112? You're right. No, at 112, they're not even combative. Like, we're clinging to life at 112, and we can't correct it overnight. It will take a week to fix that patient's sodium.
The patient I had yesterday at clinical, his sodium was 109 on admission, and it came up to 114, but he was as full as a cucumber.
So it makes you wonder how long he had been there, and had he been there before. Like, can he tolerate it? Kind of like our diabetics that run high. You can see them with a blood sugar of 1,000 and they're talking to you and just fine. And you can have others that come in with a blood sugar of 300 and they're in ketoacidosis. So it makes you wonder how well they're compensating with it. All right, so we talked about hypoxia can lead to an altered mental status. We can talk about electrolytes changing, leading to an altered mental status. What else can cause an altered mental status in a burn patient?
Dehydration? Well,
That's probably along the lines of hypoxia and perfusion. Toxins, as in things they might have inhaled, something that was burning in the building, some kind of chemical that they came in contact with, a toxin. There's one other big one, and we're going to see it when we start talking about Parkland Formula and fluid resuscitation. We're going to cause it, by the way.
Pressure, ICP.
Yes! And what is that called in patients that we're giving fluid to?
What is
You're
it
right.
called?
Yes, it's water intoxication. So, what are we doing? And it does increase ICP, and that is why they become confused. What are we doing? We have this patient that's vascular volume is dropped. I've told you that we're getting ready to pump liters upon liters of fluid to this patient. And so we're going to drastically drown them in volume. Literally, we're on that verge of keeping them out of pulmonary edema when we start putting volume on them. And when we process, the body processes water, the brain cannot process and move water or fluids as fast as the rest of the body can. So when we start giving them fluids, that brain is going to start swelling. And if it does, then we have water intoxication and we have an altered mental status because of swelling that occurs from fluid resuscitation. We're going to cause it.
Will you give hypertonic then?
You do. We do. That one is. We use mannitol because we want to use an osmotic diuretic. So tell me about an osmotic diuretic. How is an osmotic diuretic different than a loop diuretic? Because they're both diuretics.
Where the
Osmotic can,
permeability is.
like, do the thing, like if
It does this thing. What is this thing? You're right. It does this. What is that?
It can shift.
It shifts fluid from interstitial space to vascular space.
What's the difference between that and albumin then?
Albumin is going to force fluid back into the vascular space. You're right. We use albumin as well in these patients. The mannitol is going to shift fluids from an interstitial space to a vascular space. However, with mannitol, it is still a diuretic, so what's going to happen to fluid? It's going to leave the body as well, right? Because it still has that diuretic effect to it. Not in the same degree as a loop diuretic, but it will. That is why we see albumin used more so than we see mannitol. Now, if they start having that brain swelling, we have to swap to mannitol. We have to get that fluid off of the brain and back into the vascular space. But these patients are going to get lots and lots and lots and lots of albumin as well, because we're going to keep that fluid or try to push that fluid back into that vascular space with it.
Now, does mannitol have the same effect on potassium as just loop diuretics? Or?
It does not.
Okay.
No, it's not a potassium wasting. You don't have to worry about potassiums with mannitol on these patients. But now remember, the goal of it is we use it with the heads. And we'll talk about mannitol more with neuro in Module C. We don't use it a whole lot with burns, except with the patient that we do start seeing the intracranial pressure or the swelling because of water intoxication. All right. I don't know where I am in my whole
That's it for today.
No. You were wishing it was it for today. All right. When we talk about metabolic effects. All right. So with metabolic effects, these patients move into a hypermetabolic state. So when they move into a hypermetabolic state, what happens to oxygen demand? It increases. What happens to the need for caloric intake? It increases. So these patients need increased calories and they need oxygen. When we talk about calories, 2 to 3 times higher than their normal caloric need. But not just calories. Where do you think these calories need to come from? Proteins and fats. Yeah. We need something quick, and we also need something to help rebuild, to repair from burn injuries. We do see a hypothalamus reset on these patients. So when we are in this acute phase, and remember the acute phase is that second phase of burns, we will see these patients develop low-grade fevers. It doesn't mean that they're infected, but infection, the #1 killer of burns in the acute phase is infection. So now we're anticipating infection in the second phase or the acute phase, and this patient is going to have a hypothalamus reset, and they're going to start running a low-grade fever. How do we separate the two? Can we just look at the patient and say, oh, they've got a fever, they've got an infection? Nope. What labs do you want? A white blood cell count, but more specifically than a white blood cell count, what are we looking at with that differential? Bands and a shift. We're going to look at those neutrophils. We're wanting to see if there are immature, if those bands increase, because then that lets us know that they're immature and there's an infection. All right? So we're going to start looking at those differentials. What else are we looking at? Not only white blood cell counts, how else do we look to determine if the patient's got some type of infection? Okay. Lactates are going to be high anyway because of the burn process. Okay. ABGs, we'll come back indirectly, yes, maybe. There's another one. We're in the acute phase of burns. So where should their heart rate be?
I was going to say heart rate, usually hypersepsis.
Remember, we talked about abnormals in the first phase. The second phase, heart rate returns to normal, but now all of a sudden the patient's tachycardic. Now we have to consider infection. Does that make sense? We've been doing dressing changes on this patient for a week, and that wound has had clear serosanguinous type fluid coming from it, and now it has an odor and it's pustulant. We have to look elsewhere other than just a temperature to go infection. Now there's the possibility of infection. There is. But remember, it is a combination picture. It is not a single diagnostic that tells us that they're infected. Okay? So we have this whole immunologic change in this patient. This is where the whole burn process starts, is with this compensatory response, which is a combination of an inflammatory response and a sympathetic nervous system response. So you need to go back and you need to look at catecholamines. You need to look at antidiuretic hormones. You need to look at aldosterone and cortisol with this. That is that sympathetic nervous system response that we see all of these changes. With a sympathetic nervous system response, we see a decrease in the immune function of the patient. Now, does it help with healing? Absolutely, but it also will shut down that kind of that immune response that we have. So it's kind of that double-edged sword. That inflammatory response, we will see kind of settle that the immune response. It suppresses that immune function. This is, when we talk about compensatory, this is what we see. This is kind of just that diagram. It's everything we have talked about so far. We see an increase in heart rate. We see an increase in respiratory rate. We see slow GI motility. We see, we hadn't talked about glycogen storage. Let's talk about that for a second. Patient has a burn. We have this sympathetic nervous system response. What happens to blood sugars? They increase, absolutely. So now we have an increase in blood sugars. However, we will use up that storage at some point, and then what are we going to see with blood sugars? They're going to come back down. We're going to drop on us. We're going to start going from hyperglycemia to hypoglycemia in the patient. Remember, we're checking for Curling's ulcers, stress ulcers. So we're looking at hemocults, we're looking at gastrocalts, we're checking what's coming out of their NG tube to see if we have blood in those for our Curling's ulcers. We know that they're going to have generalized edema. We know this is just essentially what we are seeing in that burn patient. Pre-hospital. And we don't typically talk about pre-hospital a whole lot because y'all are going to work in the hospital, not outside of the hospital. But we have to think about pre-hospital things that we can do for these burn patients and for ourselves. One is you have to think about the safety of the rescuer. So you can't be victim number 2. You have to keep yourself safe first or you're the next victim. And that's really basic. We talk about that a lot in EMS and that side of it. But if the house is on fire and you run back into the house, now you are potentially the second victim. We see a lot of that. Houses are on fire. Somebody's in there, a loved one, a loved pet, and they go back in for that person or that pet, and they don't come back out because they're overwhelmed with smoke. They get that smoke inhalation injury. So you have to think about being safe and keeping the rescuer safe. I'll give you a quick example. Several years ago, my husband and I were leaving gymnastics with our daughter, heading on 84 back toward the circle. So we'd been out by Flowers Hospital at gymnastics, and we were heading back down 84 toward the circle. And we'd gotten to about Flowers Chapel Road, and we were having that nice conversation about, what do you want for dinner? I don't know, what do you want for dinner? As we aimlessly drive toward food, you know what I mean? And so we were there at Flowers Chapel Road, and 2 cars heading out of town initially looked like they had touched. One of them flips, hits the side, hits an electrical pole comes down, transformer hits the ground, everything goes dark in that area, and you hear these boom, boom, and the ground catches on fire around this car. The other vehicle keeps going out 84. My husband and I are both nurses, and so he's like, okay, I'll call 911, you go check on them. Thanks, baby. So I get out of the car. Can I go running up to the vehicle that power line's on? No, that is a live line. The power line is laying on top of the vehicle, and the ground is now on fire around this vehicle. 2 men are in it. We later learned that they were intoxicated. They were drunk. The driver starts climbing out of the window of his car, and at this point, the apartment complex that is there, everybody's out on their balconies watching, and I'm standing there yelling, stay in your vehicle, stay in your vehicle, don't get out of the vehicle. Do you think he listened? No. He gets out of his vehicle, his head's all bloody, and he stumbles up the hill to where I am, and I set him down on the ground, and I said, are you okay? And he said, my neck hurts. It's like, no shit. Like, every bit of you should hurt. Like, you should hurt from head to toe. I am so impressed that you're not dead. Like, that is the way I really felt when he walked up. So, of course, I laid him down, held some C-spine stabilization, waited on EMS to get there. He was talking to me the whole time, head cut open. The passenger is still in the car. It took an hour and 15 minutes to get the passenger out of the vehicle. His legs were caught under the dash. He was trapped in the vehicle. But it took the city of Dothan 20 minutes to get the power turned off to that area of town. So no one could get to that vehicle until the power was shut down to that area. So what if that man had a wide open tib fib, abdomen, and he was bleeding out for the next 15 minutes? Not a thing we can do about it. He unfortunately will die in that vehicle until you can make sure that the scene is safe. Because what if EMS had gone running up to that car to take care of the man who's bleeding out in the vehicle? They're all dead. Like, they would have all been hit by that power line that was laying on that vehicle and been dead. So we have to look at the safety of the rescuer. When we start looking at the source of a burn and stopping a burn, if it's thermal, what do they teach you in elementary school? Stop, drop, and roll. Do you know what? It still applies as an adult too. Like, if you are on fire, you don't run. You stop, you drop, and you roll. And we laugh about that, but instinctively, what is our instinct?
You want to get away from it.
It's fight or flight, right? That is it. You either run or you die. And so we instinctively tend to run. We want to cover them. A blanket, sheet, anything to get rid of the oxygen that is fueling that fire. That's thermal. What about electrical burns? Can we just walk up to them and I'm like, Jay, you're on that electrical line. Let me pull you off of it. No, because if I touch Jay, guess what? I am now victim number 2. So you have to wait until that electrical line is turned off. And by the way, have any of you ever touched an electrical fence? Yes. All right. Do you know why electrical fences pulsate and they're not a continuous stream of electricity?
You wouldn't be able to.
You wouldn't be able to get off of it. Electrical fences aren't designed to kill animals or cattle or whatever they're trying to keep in. It's to deter them from breaking through that fence. But if it didn't come through the line in pulses, you would touch it and you wouldn't be able to move away from it. Well, a current from a power line, guess what?
It's the same way. It's constant.
It's constant. It doesn't come in pulses. So a patient touches it, guess what? They don't just let go of it and walk away from it. They are stuck to it. So you have to break that current. Chemicals. We have to think about what the chemical is. There are lots of chemicals that are not activated until they're wet. So any type of powder type chemical, you want to keep it dry and you want to brush it off. You want to remove the clothing. You want to keep it away from the patient. Now, some of it's very fine. You start brushing it and you take in a deep breath, guess what? You've inhaled it. It hits the mucous membranes and now it is wet and active. So you can't just start shaking things and trying to get clothes off of them. You have to be very mindful of that with these dry chemicals because they become active when they become wet. Mucous membranes will wet them. And now we have an inhalation burn of that chemical. So yes, we want to get it off of them, but in the powder form, it's not hurting them. So you just want to get it away from the skin so that the moisture on the skin or in the mucous membranes doesn't activate it. Remember, acids we can dilute. Bases, we have to look at an MSDS. We have to look at what it is actually composed of so that we can neutralize those chemicals. And then we start with airway. It's airway, breathing, circulation. With electrical burns, we have to assume a C-spine injury. If they have an electrical burn, you assume that they have a C-spine injury. And that is because of a tectonic contraction of the neck. So the current can be so forceful that it can cause muscle contractions of the neck that will break the patient's neck. Not because they fell, not because there's a high distance, not because there's a trauma, but the sheer current itself can cause severe muscle contractions to the point the person's neck breaks. Why is it the neck that's the weakest point? I mean, if you think about it, we're really bobbleheads. Like, we've got this heavy weight sitting on this little stick, not supported by ribs, not supported by pelvis, not supported by any other muscles other than just these tiny muscles of the neck. And you think about your head being that wrecking ball. Some kind of injury goes to it and it moves, muscles contract. It's just a weak point. That's why we see lots of C-spine injuries where we don't see as many thoracic and lumbar injuries, because there's not as much support in the neck as we see in the thoracic and lumbar area. So we do see C-spine injuries, and we assume C-spine injuries with electrical burns. Does that change the order in caring for the patient? No. We are still airway first. It is still airway, breathing, circulation. Does it change how we open an airway? Yes. So now, instead of a traditional head tilt, chin lift, we do a jaw thrust on the patient. It doesn't change the order, it just changes the way we open an airway. History. Patient's been burned. You're in the ER today, and EMS is calling in on the radio to let you know that they got a burned patient. What do you want to know? You want to know the vitals? Okay. Do it now?
Like the history of how it happened.
Okay, the history. What is that history going to tell us in how it happened? What type of burn it is. So is it a thermal burn? Is it a chemical burn? Is it a radiation burn? It's also going to let us know if it's enclosed environment or open. So if they call it in and they tell you that it's a 2-story house fire and they've been trapped on the 2nd floor for the last 20 minutes, what are you anticipating? Inhalation injuries, respiratory injuries, prophylactic intubation of this patient. So we want to know vital signs. We want to know what type of burn it is. What else do we want to know? IV access because of fluid resuscitation.
Like the
Percentage of the burn, total body surface area, so the rule of nines. What else do you want to know the severity? Percentage and depth. You want them to give you a depth, you want them to give you a percentage because you know right then severity of the burn. You want to know if they have IV access because we want to know if they've got fluid started. What else do we want to know? There's one other big one. I'm really not overly concerned if they're alert or not. What else? Time is important. We're talking about that with the Parkland Formula. What about comorbidities?
diabetes, hypertension.
Exactly. All right. So do we care about all of them?
Yes.
No. We don't. Not on an EMS report. I don't give a shit if their big toe hurt 5 years ago. You know what I mean?
Yeah.
All right. So what am I concerned about? Because I'm getting ready to load them with fluids. Renal function and heart function is what we really want to know. Because if I know that this patient is a severe CHF patient and they stay in heart failure on the verge of an exacerbation all of the time, what do I have to think about when I give fluids? I'm going to give them fluids, but now I've got to adjust it and add meds to it. Because I can't give them the same volume that I would give the patient that has a healthy heart or healthy kidneys that I'm going to give to this patient. So those are kind of what we're hoping we get in that history. That is short. That is abbreviated. We get a full head-to-toe assessment and history once they get there. But that is that abbreviated. Remember, RNs have to do your initial assessment. That is Board of Nursing. That is across the board. RNs have to do an initial assessment, and all initial assessments are comprehensive. You don't get to do an abbreviated initial assessment. So go ahead, Josh, ask me the question. I'm waiting because you're an ER person. Come on. What about triage? Right? What about triage? Triage is the initial assessment. Is it comprehensive? No. So how do we get away with triage not being a comprehensive assessment? Because it has to be comprehensive. because your nursing charting in the back is a continuation of your triage. So it starts in triage, but that assessment is not complete until you actually sign out of that chart in the ER. So the initial assessment may be their entire visit, but that is where you get that initial comprehensive assessment. And so it is the job of the RN, once the patient in the ER setting sees that patient, to get the rest of the information that wasn't filled in triage. Does that make sense? Alright, I told you there are 3 phases of burns. Here they are. We have the resuscitative emergent phase, we have the acute phase, and we have the rehabilitative phase. Now, I'm telling you right now, if you memorize these phases based off of time frames, you will not be successful. You have to know these phases based off of what occurs in the phase. So let's talk about it. So, the resuscitative emergent phase, it is approximately 48 hours. I'm not doubting that, but that varies from patient to patient. This phase ends when diuresing begins. So for me, it could be 42 hours. For Jay, it could be 72 hours. But this phase doesn't end until diuresing begins. You're like, okay, Dr. Neal, diuresing begins. We just talked about how dry these patients are. How are they going to diurese?
Well, then what about like heart failure patients?
We're going to talk about heart failure patients. We're going to add meds, and we'll talk about that with Parkland Formula, but they will diurese as well. Our renal failure patients may not diurese, but we're going to adjust that with CRRT or with dialysis. And so we'll know that fluid shift with dialysis. So let's talk about it. So the patient has a burn. That is when the time of the burn, that's when the burn time starts. That's when this 48 hours starts, at the time of the burn. For approximately 24 hours, we have that sympathetic nervous system response, that inflammatory response. We have capillary leak syndrome. We have fluid shifting from an interstitial space to from a vascular space to an interstitial space. We have fluid we're losing. Somewhere around 24 hours, and it's not specific, but somewhere around 24 hours, we regain that vascular integrity of the capillary beds. And the capillary beds say, uh-oh, I have a job I've got to do. Wait a second, I've got to wake up and do it. And so we see those vascular beds start holding on to the fluid that they have. We then start seeing an osmotic type gradient work, and we see fluid start moving from the interstitial space back to the vascular space. So fluid loss, about 24 hours we hit a neutral type period, and then from 24 to 48 hours we have what we call remobilization. And that is where that fluid starts moving from the interstitial space back to the vascular space. All right? So as fluid remobilizes and we have fluid moving back to the vascular space, what happens to vascular volume? It increases. As vascular volume increases, kidneys that weren't being perfused are now being perfused, or kidneys that were barely being perfused are now being perfused much better. And what happens to urine output? It increases. So this phase ends when diuresing begins. And that is because we know we've had a turnaround of fluid shifting. Does that make sense? So it's not about 48 hours. It's about, are we still in a fluid shifting state, or have we come out of that fluid shift? And so we hit 48 hours, we now are diuresing. We're no longer sending fluid to an interstitial space. We actually have fluid coming back to the vascular space. What's going to happen to edema? It's going to decrease. What's going to happen to potassium? It is going to decrease. So potassium's high initially, but potassium's going to move back to the cells. So potassium comes down. Sodium's the one that's a little tricky. Sodium's going to be low initially. We remobilize, and where does sodium go? Wherever what? Wherever water goes. Where's the water going? Out of the body. So guess what? Sodium goes with it. Sodium starts low and stays low through that phase. So potassium starts high and returns to a baseline. Sodium starts low because where's sodium going initially? It follows water. You just told me that. So where is it going initially? Interstitial space. So sodium starts low. We remobilize. We're diuresing. And where is sodium at the end of the phase? Still low. That's right. It's still not in the vascular system. So this phase ends with diuresing. From diuresing to wound closure is our acute phase. So let's talk about priorities for a second. In the resuscitative emergent phase, what's priority? That first 48 fluid shifting time frame, what is priority? Volume and keeping them alive, right? Perfusion, getting organs perfused, keeping the patient alive. That is really priority in that first phase. However, we get them through that phase. Hypovolemia is not a problem any longer. We don't worry about the shock. We don't worry about the poor perfusion of organs. We now move into the acute phase of burns. And the priority here shifts from keeping them alive to preventing infection. Because now this is the phase that we work so hard on getting that wound covered. We're trying to prevent infection in these patients. We want to work on those wounds. This is where you're going to see a ton of your wound care done. Now in the first 48 hours, what are we doing with actual wounds themselves? Many times it may just be sterile dressings and covering them. Occasionally maybe a debriding. But because that phase is so short, we are literally just sterile dressing covering those wounds. But now we got to address them, right? Now we're in that acute phase. They're no longer hemodynamically unstable as we move into the acute phase. Now we've got to address the wounds. Now this is where all the debriding comes in. This is where all the dressing changes come in. This is where we focus on preventing infection and getting that wound covered so that we can get through this phase. Once we get that wound covered or closed, we then move to the rehabilitative phase, and that is to our highest level of function obtained. That varies. Like I might hit my highest level of function in 6 months, but we give them up to 18 months to hit that highest level of function. Is where that rehabilitative phase comes in. So now you see, I've told you there are 3 phases, but the majority of what we talk about is in that first phase. It is where the patient is hemodynamically unstable. We see the biggest shifts in fluid. We see the biggest changes in electrolytes is in that first phase of burns. And then here's exactly what we were just talking about. That first phase, that resuscitative emergent phase, what is our goal? Our goal is for us to, one, keep an airway and keep the patient breathing. It's perfusion of vital organs. When we talk about comfort, we haven't talked about comfort yet, and burns hurt. So let's talk about comfort. Giving them pain medicine for pain. Yeah, narcotics for pain. Let's use something else besides that. How do you think we administer pain medicines in the resuscitative emergent phase? It is IV and IV only. We do not use IM and we do not use sub-Q and we don't use PO. All right, IM pain medicine will last longer than IV pain medicine. So why do we not use IM and sub-Q pain medicine? They last longer.
Tissues are already
Tissues could be compromised. I'll find somewhere else to give it. All right.
It's the absorption process.
Okay, so what about the absorption process? Because they're not absorbing it. You're right.
Because it's like the swelling of it's messing up how the medicine's going to be distributed.
That's right. So what he's getting at is the patient is shifting. They are third spacing. So fluid is moving out of the vascular space. So if we give them sub-Q or IM injections, is that medicine going to move into the vascular space for metabolism?
No.
It's not. It's going to sit in that interstitial space. It's going to sit in the muscles. It's going to sit in the tissues and do no good for them at all. All right, why don't we use the PO? They might not be able to swallow, but I can put it down the NG tube. Their GI tract is not necessarily working. Remember, they may have very hypoactive or absent bowel sounds in this resuscitative emergent phase. And so we're not going to put something on their stomach that they're not going to use. They can't process. It'll just make them sick. We'll just throw it up, or we'll suction it out through the NG tube. Preventing infection, we're looking at sterile dressings. Maintaining a body temperature on them. Remember, these patients tend to get cold, so we've got to keep them warm. Things like keeping them dry is a big one. We lose body heat 25 times faster wet than we do dry. So if they're sitting there with wet dressings over 50% of their total body surface area, are we going to keep them warm? No, we're not. So we've got to think about keeping them dry to keep them warm. Think about where we lose body heat. Where do we lose body heat fastest? Head? Is that why you got your head covered? My husband's bald, and he wears a toboggan about half his life. I'm like, Johnny, just let your hair grow back out. No, I like my head shaved. Okay, just stay cold. Okay, got it. We lose heat through our head. So what can we do? We can put warm blankets and towels around their head. Think about their feet. We lose heat through our feet. You get hot, what's the first thing you want to take off? Socks and shoes. Well, me probably my bra, but you know, socks and shoes. And so we take our socks off so we can cool off, because that's where we lose body heat. We also need to think about things like warming blankets, bear huggers. We need core temperatures, so rectal temps, esophageal temps, bladder temps. Those are all core temperature measurements. You can get those core temperatures in any of those ways. Your esophageal is actually your most accurate, followed by your bladder and then your rectal temp. Emotional support. We don't focus a whole lot on emotional support in the resuscitative emergent phase. If we're focusing on emotional support, it's probably not for the victim, it's probably for the family at that point. When we get into that acute phase and we get into the rehabilitative phase, then we have really got to look at the psychological effects of burns. My roommate in college, while I was in nursing school, her fiance at the time, he was an electrician working in the attic of a house. They were built a new construction house. He was in the attic working, and something happened and a gas line exploded in the attic. And he was an electrician in the attic, burned severely. Disfigured his face, his head, most of his upper chest. He lost some fingers on both of his hands. Months and months and months of hospitalizations and rehabs, but no one ever addressed the psychological effect of the burn. He was mad at the world. He hated everybody. He hated everything. He felt like he had been dealt the bad hand, the wrong deck, to the point that he would almost like self-sabotage any type of a relationship he had. Ultimately, their marriage failed because no one ever addressed his burns, never addressed the psychological effect of the burns. He probably felt robbed, and he should have, right? Is that a very valid feeling? Absolutely. Like, here he was as a productive member of society, had an engagement, was on his way to being very successful, and all of a sudden, in the error of someone else, he spent 6 months in hospital and rehab units, lost part of his arm and his hands, very disfigured, felt like people stared at him all the time. Initially I noticed it, but after a while you really you didn't notice it. He still had normal hair patterns, so they were able to cover some of it. He kept his hair a little longer. He was able to cover some of it. But they never addressed the psychological issues. So we have to address those psychological issues with burns as well. We talked about histories when we talked just a minute ago. Comorbidities, a big one. Remember, many times though, we have burns that are, we have patients that come in that are burns that are not just burn patients. They are trauma burn patients. And as a matter of fact, probably the majority of the burns that we do see are trauma burns. They're vehicles that they've had a wreck, they've crashed, and the vehicle is caught on fire. So not only are you looking at the burn injury, but you also have to consider the trauma that has occurred as well. So you may have that combination of a patient that comes through your ER with burns. When we look at diagnostics with burns themselves, just burns, assuming there's no trauma with it associated, radiology-wise, usually chest x-ray is all we need. It's typically what we need with burns. Now, they're a trauma burn that's been in a car wreck. They may get a head CT, a head, neck, chest, and abdomen, but that's not because of the burn. That's because of the trauma that was associated with it. Bronchs, again, we look at bronchs sometimes just to look at airways to see the amount of damage they have, and then later, that 72-hour mark, because of sloughing. We start having airways that are occluded because of the lining of the lungs that's sloughing off. So you may see them bronchs at 2 different times in the burn phases. If we have burns to the face, we need to look at their eyes as well. And then labs. In the ER, labs are your baseline. We draw 400 million thousand labs all the time in ERs. Why? Because we don't have a picture of this patient prior to that. So we've got to get a baseline. And yes, it gives us a lot of diagnostics up front, but guess what? 5 days into their visit, it gives you trends. It lets you know where they started and where they're going. So that is one of those big things with ERs. We get lots of labs because we need a lot of, I always felt like I was an investigator. I always felt like somebody came in and they're always the world's worst historian. They can't tell you shit. And you have to figure out what's wrong with them, right? So I always feel like I'm playing detective when I'm in the ER. And that's when you start. What do you want to know? Well, I want to know if they have an elevated white blood cell count. I want to know, and so you get labs. And so that's kind of your baseline, but it's also important a week down the road in the unit, they can go back and look and go, okay, this is where their sodium was when they came in. Where are we today? And so it gives you that baseline, that starting point. When we look at labs, don't forget your drug and alcohol screens. They are positive more often than they're not, where the patient wouldn't be in the ER. Like, that's just the reality of it. With burns, of course, we need ABGs. We need just basic, general, across-the-board labs for these patients. When do we need something more specific? They have a history of cardiac issues. They're hypovolemic, poor perfusion, and now they're complaining of chest pain. Could they be having an MI? Absolutely. So think about their history along with, or their comorbidities when you start looking at labs. The 85-year-old that has a burn needs cardiac workup. The 22-year-old with burns probably doesn't. So you have to kind of look at those histories as well. Rule of nines. What? There it is. All right. Total body surface area. We are going to use the rule of nines. There are several. The Ludd and Browder and the Burklow are 2 other ones. I'll show you one of those here in just a minute. But the rule of nines. In areas that we don't hit the rule of nines, you can divide or you can use the Palmer method. So let's talk about it for just a second, because you probably didn't understand everything I just said. So Anatomical position, the anterior side of the body, the right arm is 4.5%. But now, when they say 4.5%, they're saying from fingertips to shoulder is 4.5% of the anterior arm. Well, let's say I was carrying a hot pot of boiling water and it boiled over on me and I'm only burnt on my hand and my forearm. Is that 4.5% of my total body surface area? No. It's not. So what can you do? Now remember, the Parkland Formula is a ballpark. No, I lied. The rule of nines is a ballpark. It is a fast way to get an idea, a generalized surface area. What I can do is I can take this 4.5 and I can divide it in half. And I can call this 2.25 and this 2.25. Other than that, we're not going to divide it down any further than that. You can divide it in half, but then call it quits at that. The leg is 9% of the total body surface area. Let's say I'm only burned on my feet and my calf. Well, is that 9% of my total body surface area? It's not. Divide it in half. 4.5, be done. Does that make sense? So you can divide in half, but don't divide any further than that. The abdomen and chest on the anterior side make up 18% of the total body surface area. That's also known as the torso or the trunk. Makes up 18% of the total body surface area. But you can divide it in half. You can call the abdomen 9 and the chest 9. Areas that don't fall into that, boiling water, grease, those type of things that tend to splatter, you might use the Palmer method. The patient's palm is 1% of their total body surface area. So does that mean I can take my palm and measure it and tell that that's 1% of Jay's total body surface area? No, I can't. It's the patient's palm is 1% of their total body surface area. So you can figure it out, measure it out, about the size of my fist, and start dotting it out and come up with your surface area. But then when you start charting it, you chart it 4% collectively using the Palmer method. So that we know that you got 4% of the total body surface area, but it wasn't 4% together. It might have been 4% in an area. Does that make sense? Mm-hmm. So you can take the rule of nines, you can divide some area of it in half, but after that, you look at a Palmer method. You look at the patient's palm being 1% of their total body surface area.
So if like the torso area is divided 9 and 9, can you divide it any further than that?
You can. I mean, you can
Like
you can take this on the right or left side of it. Yeah, you can take that 9% and go 4.5. But I wouldn't go any further than that. No. So that is the rule of nines. Now, is it exact? No. Does it take into consideration obesity? No, it does not. However, it is the most widely used and it is what is tested and nationally accepted. So we use the rule of nines. There are some faults to it. I'm not telling you it's perfect, but it gives you a ballpark of total body surface area. If I had EMS call in and tell me that they had a patient with 20% of their total body surface area burned versus 75% of their total body surface area burned, I have an idea of what we're looking at with patients, right? When we look at depth, we are learning depth with characteristics. That's what we spent the first hour talking about. The superficial, the partial thickness, the full thickness, and the deep full thickness burns. That is characteristically determining the depth of the burn. How does it look? What does it present like? What are we seeing? Is it red? Is it moist? Is it hard and leathery? That is what we're looking at, characteristics to have an idea of the depth. Now, do you think that's the most accurate way to determine depth? Nope, it's not. Is it the quickest? Absolutely. But more accurately, you're going to use some type of imaging, Doppler, ultrasound type depth. What are we really looking at with all of those? Blood flow. That's what we're really looking at, is blood flow. Where do we have blood flow and where do we not have blood flow gives us the exact depth of the burn. So characteristics is really quick, but it's not the most accurate. That is the Lund Browder. Just another one that is used. You don't need to know it. Just showing you that there's different ones out there. With this one, you tend to see this one used more in pediatrics because you do have ranges for age groups. And then we classify our burns as minor, moderate, and major burns. And that is the percentage of partial thickness and or full thickness burns that they have. So a patient that has, a minor burn is 15% of their total body surface area or less. Let me preface this by saying, you notice it says partial thickness or full thickness burns in percentage. You don't classify superficial burns in your rule of nines. Superficial burns don't count in the rule of nines. Okay? Why? Because they're so minor in depth that they don't count. We've had patients that have come in, been burned with tanning beds. They've been burned over 100% of their total body surface area. If that were partial thickness or full thickness burns, they'd be dead, or we'd really be concerned about them. But it's superficial, and so therefore it doesn't count in your rule of nines. So superficial burns don't count in your rule of nines. So when we start talking how we classify them as minor, moderate, or major, it is partial thickness or full thickness. It has to hit that dermal layer. So 15% or less are minor burns. Moderate burns are 15 to 25%. And major burns are anything greater than 25% of the total body surface area. We prophylactically intubate at 25%. We put A-lines in at 25%. We put NG tubes in at 25%. We start the Parkland Formula at about 20% of the total body surface area. Now, does that mean the person that has 15% of their total body surface area doesn't receive fluids? No, we just don't officially use the Parkland Formula. So about 20% of their total body surface area will start with the Parkland Formula. 20% of partial thickness or full thickness burns. Of course, you've got to think about areas of thin skin. You've got to think about other things that can contribute to the burns, comorbidities, traumas associated with them, the age of the patient, inhalation injuries. All of those can make those burns worse. So we have to think about those. What does age have to do with it? Their skin is thinner. What else?
They don't heal as well.
They don't heal as well. They have a decreased immune response. They also have decreased lung compliance as well. Their lungs just don't work as well as ours do. So those age alone can put this patient at a greater risk. All right, guys, we are done with burns for today. Was that thank God or? All right, so don't worry if you didn't pick it all up. It's okay. Guess what? We're going to repeat a lot of it come Thursday. We're going to look at it from the assessment side on Thursday. We've talked about the process. We've talked about what's happening. Now we're going to pick up and look at it on Thursday is what are we assessing? What are we looking for? What do we anticipate seeing? What are we finding? We talked about a lot of that today because we talked about the process. But now we're really going to look at it on Thursday from that patient has come in our doors, what do we do? Is what we're going to look at.